we go next to...
Well, the next presentation is from Maurizio Taramasso, and he's going to give a presentation on Abbott's TAVI device, which is quite a low-profile device. It's got a clever way of sealing, and it's readjustable, it's repositionable, so...
Yeah, thank you. I just try to connect my laptop, and it's a pleasure for me to talk a little bit about TAVI, and in particular about the Navitor Vision platform, which is, I would say, probably my favorite TAVI platform for a number of reasons that I will try to explain you, and then we may have eventually some discussion. Actually, the reason why I really like the Navitor Vision platform is that it is a self-expandable valve, so that means that it has all the advantages of an excellent hemodynamic of self-expandable TAVI valves, together with an excellent predictability of implantation. So the valve is recapturable and repositionable, but it is extremely stable during the implantation. There is no diving, similarly to what we have when we implant a balloon expandable valve. So we have the hemodynamic of a self-expandable with the easy to implant and the versatility of a balloon expandable. And this has been even implemented in the last iteration, which is the Vision, where actually 3 marker has been added, I will show you later on, to allow even more precise implantation. And then a bigger sizes, which is a 35 millimeter valve size, have been added to also cover larger annuli, which are quite common in Europe, probably even more in US. This was actually something that was lacking before. Now with the 35 valve, which share the same low profile as the smaller one, we can cover virtually all the annular ranges with this Navitor platform. And obviously having a good valve, which is easy to implant and with low profile and excellent hemodynamic, translate in good clinical outcome, which is what at the end we actually care and what at the end matters. There is extremely low incidence of paravalvular leakage. Mortality, even in high-risk patients, is extremely low, with a really low incidence of stroke, vascular complication is also extremely low, and mean gradient of 7.5 overall, including also small annuli, is an excellent result. This is actually the consequence of the detail that has been actually put into design of this valve. There is a number of features that explain why the outcome are good. The first one is that the valve, being in nitinol, so self-expandable, has large cell design, and the large cell design allows accommodation also of asymmetrical and bulky calcification, so mitigating the risk of paravalvular leakage. Having a radial strength which is comparable with other platforms with more metal. The large cell design allows also easy coronary access after TAVI, so it's extremely easy to engage the coronary after the TAVI. Also together with the fact that the valve is intraannular, so we don't have a supraannular leaflet valve that can eventually, if we don't perform commissural alignment, preclude easy coronary access, so it's extremely easy to access the coronary after. There is 2 mechanisms of preventing paravalvular leakage. There is an inner skirt, so we have a covered cell, and then there is this outer active sealing cuff, so this mitigates also in calcific anatomy the chance of having paravalvular leakage. And then these 3 radiopaque marker, as I told you already, allows you not only to perform perfect implantation at the desired height, but also to check the orientation of the valve and to perform commissural alignment if you want to do it. Last but not least, the delivery system is probably the best one at the moment among the commercially available TAVI system. It is the FlexNav system. It is compatible with a 14 or 15 French sheath, 14 for the 23 and 25, so the smaller sizes valve, 15 for the 27 to 35 millimeter valve. So also the 35 valve is delivered through the 15 French compatible delivery system. It is extremely flexible and hydrophilic, so we can really perform transfemoral procedure even in extreme tortuous anatomy or in calcific. So usually when you have a challenging peripheral access, independently or what is the anatomy of the aortic valve, usually our favorite choice is to go for Navitor because of the flex nav. Flex is really an excellent delivery system. As I told you, 35 millimeter valve fit in the 15 French delivery system, so we don't need any bigger delivery system, so we can really treat up to 5 millimeter patient, so patient with 5 millimeter valve, even with the large 35 size Navitor. The marker, which is the most important add-on on the vision, you see these 3 radiopaque marker are really visible. And the deepest point is 3 millimeter, the highest point is 4.5 millimeter, so you can really target high implantation in a really precise way. And this is extremely important, not only to be really precise in positioning, but also to get rid of the parallax. When we want to release the valve, we don't want to have any parallax. So having these 3 markers aligned make us really sure that we don't have parallax, so it's extremely easy and fast to align the fluoroscopy to the valve. And then we are able to check commissural alignment. It's not yet in the IFU, the technique to perform commissural alignment, but it's quite easy and reproducible to do it, and for sure it's extremely easy to check it at the end. We do commissural alignment in all the cases, at least we try to do it. Here you see how the combination of the inner and outer skirt together with the large cell allows extremely good sealing. So you see the bulky calcification are accommodated in the large cell, and then the sealing cuff are usually really counteracting any paravalvular leak. So it's quite rare to have severe or moderate paravalvular leak. Obviously, we can have some mild paravalvular leak, but relevant paravalvular leak is extremely uncommon among all the valve sizes. And this is also due to the fact that with the Navitor, the opening force and the radial strength of the valve is consistent with all valve sizes. So we have adequate expansion and adequate radial strength to expand the valve even in calcific anatomy. The excellent hemodynamic, as I told you before, even if the valve is intraannular, the mechanism of opening of this valve, so the leaflet of the valve, they open up to the stent, so they completely open. So the effective orifice area is bigger as compared to supraannular valve with the same sizes. So we really have single-digit gradient, even in small annuli. You see, 23 millimeter valve is quite rare that you need to use 23 because that means that the patient has a really small anatomy, but it's not uncommon that we have maybe obese patient, female with larger bed surface area and small annuli, and 23 millimeter Navitor ensure really excellent hemodynamic even in this challenging situation. Last but not least, one of the weakness of self-expandable valve is an supposed increased risk of AV block, so with need for pacemaker implantation. Well, it is true overall, but if we implant properly in cusp overlap with high implantation, we have single-digit incidence of pacemaker implantation with Navitor. So we should properly implant, obviously in the right patient, and we can really have about 6% of permanent pacemaker implantation after the valve. So again, the marker allows us to implant at the desired high, which is between 3 and 5 millimeter. And if we respect this, usually the pacemaker rate is low. The combination of large cell with the intra-annular leaflet configuration allows coronary access in virtually all the cases after the TAVI, especially if we perform commissural alignment. And then also the durability data at the moment are excellent. Obviously, we don't have long-term data, but up to 5 years, it's almost 1% freedom from structural valve deterioration, which is extremely appealing also if you treat slightly younger and low-risk patient. If we treat a young patient, Navitor is also a good platform for revalving. So if we plan already to perform in the view of, let's say, lifetime management of patient, and the neo skirt, so if we do a TAVI in TAVI after Navitor, we have a relatively short neo skirt, so the risk of coronary problem during the second procedure is relatively low. So this is really an excellent choice if we want to treat a patient where we are already planning a second procedure in the future. How to achieve this result? Well, there is a well-defined best of practice technique to implant Navitor. I think just quickly, it's important to perform proper predilatation it's important to start the initial deployment in cusp overlap, so in areocaudal. I'll show you one case in order to be sure that we have the right high in the non-coronary cusp, which is the major predictor of risk of AV block after. So if we start with the stent of the valve at the level of the nadir of the non-coronary cusp in cusp overlap view, usually the valve dive maximal 3 to 4 millimeter and is extremely stable during the implant. So we can really achieve this desired implantation that has to be checked obviously before the final release. And that's it. It's extremely easy to perform even in larger anatomy. We know that if we implant a self-expandable large valve like the 35 Navitor or the 34 Medtronic, it is usually more challenging than a small one because the time to get contact on the opposite side of the annulus is longer, so the valve can eventually move. So I show you here a couple of examples of 35 valve that actually is extremely stable. This is a case of a patient with cardiac amyloidosis, so high risk for AV block, high risk for complication with 91 millimeter of perimeter, so really large valve, large LVOT, calcific valve and horizontal aorta. So it was not feasible to achieve the proper cusp overlap view because it was caudal 50, so basically almost impossible to achieve. We perform a 24 millimeter predilatation with a non-compliant balloon, which is our favorite balloon for TAVI predilatation. And you see there is parallax here because we were not in the perfect cusp overlap, but in the cusp overlap in the areocaudal, you check the depth in the non-coronary cusp, and then you move to left caudal, you get rid of the parallax, and you check the high of the tree marker. Here we are about 4.5, 5 millimeter, which is a definitely acceptable depth of implantation, and then the valve is released with only minimal paravalvular leakage. And this can be reproduced also in extremely calcific anatomy. This is another 35 valve that we did. You see the annulus is 27, 28 millimeter. This is extremely challenging anatomy, high risk for rupture if you perform a balloon expandable, high risk of paravalvular leak. There is bulky calcification in the LVOT. And again, we implanted a 35 Navitor in this case. We perform obviously predilatation again with 24 balloon. And then here you see the final result with only minimal paravalvular leakage and high implantation, no pacemaker, and good sealing even in this extreme calcific anatomy. Obviously 35, as I told you, is slightly more challenging, but I would say there are not that many different than implanting at 29. As a general recommendation, I think is important. I do predilatation in all the cases with Navitor, but here is even more important to perform proper predilatation. I recommend you to use non-compliant or semi-compliant balloon and to base your balloon choice on the perimeter derived diameter rather than on the minimal diameter. So to be a bit more aggressive in 35 implantation. I always use fast pacing for the valve. In 35 is even more important to stabilize the implant. And then slow deployment is a good rule for all sizes to open the valve slowly. Here there is a lot of metal, I think is even more important. Last but not least, this is true for all the sizes. According to the IFU, we are allowed to recapture only twice. Then we have to remove the valve and crimp a new one. This is due to the fact that the nitinol, if it is recaptured too many times, it loses radial strength. I think it's really important in 35. There is a lot of nitinol, so after 2 or let's say 3 recapture, it's really important to recrimp it, to change the valve, because then we may eventually lose some radial strength. Last but not least, if you need to recapture, since the valve has a lot of metal, it's important to align the delivery system. So if you have an horizontal aorta in this kind of angle, could be challenging to recapture the 35 valve. So you have just to centralize the system and then it will work without problem. But this is a small trick that you have to keep in mind. And to conclude, we had the privilege to be part of the Center of Excellence program of Abbott Navitor. So if you want to start a program, we have 3 different programs. One is for center, and we actually had already a collaboration with a center from Sofia, so from here, that to start TAVI at all. And then we have the onboarding program for center already active with TAVI, but that want to start with Navitor. And then we have also an advanced TAVI course for already experienced operator, where we do mainly case observation with complex anatomy like valve in valve or bicuspid or whatever. So if you are interested, I would be extremely happy to host you in our center and to share experience with you. Thank you for the attention.
Are there any questions from the audience? If not,
I just a tiny comment. You did show that there was a little bit of regurgitation on your video, but it's very common, particularly when you remove your Safari wire,
Yeah.
that'll go away. The huge benefit from your device is you're able to reposition it. How often in practice do you need to do that once you're experienced? But it's a wonderful ability to readjust the device.
Definitely. Usually, with Navitor, it's quite uncommon because the valve is extremely stable. So if you start at the optimal depth, it doesn't move. So it doesn't dive, it doesn't. So it's quite uncommon that you need to reposition. I would say that you need to reposition maybe in 15% of the cases, something like that. Usually, it's highly depending on the patient. There are some patients where you don't foresee the need for post-dilatation, where you can eventually release even at almost zero high. And then there are patients maybe with highly calcific valve when you eventually need to do post-dilatation, at least in your mind, before the final release. And then in those cases, if I am rather high, I eventually recapture to go a bit deeper, because if you do post-dilatation, the stent will shorten further and it can eventually pop out. But I would say it's quite uncommon that you need, so about 15%, I would say. Yeah. But these are great features, yes.
a couple of questions. Can you use it in bicuspid valve?
It's an off-label indication. So formally, no, it is not approved for bicuspid. We have been doing, obviously, not all the bicuspid are the same. If it is a true type 0, according to the severe classification, so with no RAFE and bulky calcification, it's different than if you have a type 1 or type 2 where you have 1 or 2 RAFE, but the configuration is more similar to a tricuspid valve. I would say that you need the more aggressive predilatation in bicuspid. You need almost always to do post-dilatation. But since this valve works really well, even if it is elliptical, you can do it, yes. But again, it's an off-label indication.
So when they build the Medtronic valve, they used the Hancock 2 platform, which was a traditional valve with excellent durability. When they built the Edwards, they used the Magna Ease, also excellent valve. What was the platform you had for Navitor, and what's the durability expected to have with Navitor?
Well, they have with the Navitor a new anti-calcification treatment, so it's slightly different from, it's coming from the St. Jude experience. So that was Abbott, but it was from the St. Jude experience with the surgical valve, so with the EPIC. And then they had also the Trifecta. The Trifecta was failing, now it's not anymore on the market, not because of the, let's say, degeneration to the calcification, but because of the fact that the leaflet were mounted outside the stent, and there was a real traumatism between the leaflet and the stent. So initially it was a good hemodynamic, but then the leaflet were tearing due to this mechanism. So, but the anti-calcification mechanism that they use in Navitor is a new one. We have data now up to 5 years. We don't have longer term data. I think it is expected to be at least comparable to Medtronic, to the other platform, but we obviously need, let's say that there is not yet indication for low-risk patients. There is an ongoing trial, which is the Vantage trial in Europe for low-risk patients, so younger patients. And based on this patient with longer life expectancy, we will probably get also long-term durability. But so far, most of the patients treated were around 80-year-old, so we don't have huge long-term data.
Thank you very much.